Okay, first of all, I am Dr. Aswad bin Muhammad Amin, emergency physician from EDHKL. Would like to get very thankful to Dr. Syazatul Syakirin binti Sirol Aflah. She's a respiratory physician from National Respiratory Center, IPR, just beside our our HKL. So I think it's fortunate for us to have her today in this morning to share with us regarding COVID-19 management. So without further ado, I would like to invite Dr. Syazatul Syakirin to deliver her presentation. And Dr. Syazatul Syakirin, the platform is yours. Thank you.
Okay, thank you so much, Doctor. So I'm Syakirin from IPR. I don't think so. I don't think I don't think many of you know me. So basically, I'm respiratory physician since in IPR since 2017. So I've been given a task and opportunity to give a talk on COVID-19 organizing pneumonia. Sorry for the additional pneumonia there. So instead of giving COVID-19 organizing pneumonia, maybe I'll touch a little bit on post-COVID-19 lung complication instead. So these are my outline of lecture. So perhaps we talk about a little bit on COVID-19 and lung, and we move a bit on just recognizing the imaging that I suppose that you are familiar with, and a little bit on the treatment and when does respiratory consultation comes in, and a few case sharing. So perhaps this is not really an alien to you. This graph actually showing that a timeline of following SARS-CoV-2 infection. So when there are two phases, which we call as the viral and also post-inflammatory response phases. So why do we need to know these phases? Because for early cause of disease, the host will actually experience the viral responses phase, whereby the patient presented with fever, dry cough, and perhaps mild constitutional symptom, and they will have lymphopenia on the full blood count. And basically, following that, the host already recognize there is a virus entering into the host and try to respond towards it. So whether it responds appropriate or just nice, or it responds overzealous or over response. So that's where the overlap of primary phase happen, and followed by a hyperinflammation phase. And if we look at the category, so we could actually propose that those who are asymptomatic or just having few light illness without respiratory compromise, they will categorize as 1 and 2. Those with the pneumonia means that the chest radiograph shows some pulmonary infiltrates, but again, there's no oxygen impairment. They categorize as 3. And the one with the respiratory compromise will go for the Cat 4 and Cat 5. But I guess this category could happen to anyone at any age and any gender, and with various comorbidities. So just introduction on the lung. So basically, the virus, the SARS-CoV-2, affecting straight to the alveolus. Why is that so? Because of the high ACE2 receptor receptors in the lining of the alveolus. So basically, alveolus is actually comprises by your type 1 and type 2 pneumocytes. So your type 1 pneumocyte actually responsible for the process of gas exchange between the alveoli and the capillaries, and the type 2 is actually responsible for the secretion of the primary surfactant, which actually reduce the surface tension in the alveoli. And you may understand why in the category 4 and 5, there'll be so much a compromise in the oxygenation. So we bring back to here. So the SARS-CoV-2, the virus, has 4 main structural proteins. So there are 4 proteins that known as the SMEN. So S for spike protein membrane, and E for the envelope, and N is for the nucleocapside. So the one that the main structural protein that that actually help to bind the virus to the host is actually the S protein. So the S protein has 2 subunits, S1 and S2. So when there is a binding to the ACE2 receptor, this is the entry point to the host. So this S2 actually, when the binding happens, this will induce viral replication, and the host will start to actually respond to it, and this is the main contributing factor to the immunogenic response. So the ACE2 receptor, as I mentioned earlier, is highly expressed in the bronchial epithelium, and also you could actually found in the nasal epithelium as well, and many other organs. They have described in the kidneys, in the gut, and even in the brain as well. And the factor for the binding efficiency is actually depending on the age and also the gender. So they saying that the elderly and also the male gender has a higher affinity towards this binding of the ACE2 and the S protein. And once the virus entered into the host, so the endocytosis occur, and there will be viral maturation, and also there will be viral replication, and they will release more virus within the cytoplasm of the host cell. And the magnitude of the innate antiviral response of the host is actually very variable. It depends on the degree of infection, and also that's where you actually observe all patients will actually presented differently. And this is what you call a heterogeneous viral response. So back to where the SARS-CoV actually attacked. So it impacts primarily at the type 2 pneumocytes. So this type 2 pneumocyte actually responsible for your release of your surfactant. So your alveoli technically will be stick to each other, and it will because of this there's lack of surfactant, and that lead to the alveolar collapse. And this recognition of these type 2 pneumocytes and alveolar macrophage also in the alveolus, it will actually promote the secretion of the pro-inflammatory cytokines and chemokines. So you've got a numbers of cytokines and chemokines that has been produced after this immunogenic response being triggered. So one of it is I highlighted interleukin-6. That's where you actually targeted one of the therapeutic treatment that targeted to the interleukin-6 receptor that actually you use the tocilizumab besides your steroid therapy to actually calm down or cooling the hyperinflammation phase. And with all this recruitment of inflammatory, some of it actually will further exacerbate the inflammation, and some of it has a pro-fibrotic component. So therefore, this inflammation has a feedback loop. So if there is a positive pro-inflammatory feedback loop, this will lead to further multi-organ involvement, and it will lead to acute respiratory distress syndrome. So again, what I have actually mentioned earlier, so this is how it happened. So this is in general what is meant by the cytokine storm. So whether it's a pathogen-induced triggers, or it could be iatrogenic causes, or in our context, we're talking about the COVID-19. So this will actually trigger the cytokine storm that release all the chemokines and cytokines which I've mentioned earlier. And if it's prolonged and there will be there's a positive feedback loop, this will lead to the systemic inflammatory effects and also cause a secondary organ dysfunction, multi-organ failure, and subsequently death as a outcome. So um, the COVID-19 or SARS-CoV-2 pneumonia, especially those in category 5, somehow when they study, they have some similarity between, in acute exacerbation interstitial lung disease. So what they found that the hyperinflammation similarity, they could actually see same cytokines that actually have been observed in the acute exacerbation interstitial lung disease as well. So this is like your interleukin 6, interleukin 1, your TNF alpha, and also the coagulation derangement. So there will be elevated ferritin and D-dimer. So somehow, that's where the high dose steroids idea comes in. How we treat in acute exacerbation interstitial lung disease with the high dose steroid. But this acute exacerbation interstitial lung disease is a cryptogenic or maybe an autoimmune related cause that trigger it. As compared to in our context, it is an infection. It's a virus that trigger this cytokine storm that has a similar pathway that what we see in the acute exacerbation interstitial lung disease. So the question now, are we going to adopt the same treatment what we're doing in acute exacerbation interstitial lung disease in the maybe category 5 of your SARS-CoV-2 pneumonia? So the question is to be answered later. So they talk about Hyp or silent hypoxemia, especially in viral pneumonia. Not just COVID-19, you also observe in your pneumocystis jirovecii pneumonia, whereby you have a patient that have a diffuse pulmonary infiltrates on chest radiograph requiring high flow oxygen support, but patient appeared to be not so tachypneic, little bit happy, as compared to those versus the bacterial pneumonia in sepsis. So they found that dyspnea in about 20 or close to 20% in the study actually showed patient that with the COVID-19, despite of low PaO2 and FiO2 ratio, about 86% has an abnormal CT scan and commonly require for supplemental oxygen. So the reason why they have this silent hypoxemia is how does it different from ILD? So if you have someone with acute exacerbation ILD, even at the stage of just mild, they are very symptomatic. As compared to the same degree of what happened in the SARS-CoV, they can be a so-called what they call silent hypoxia. So this is what they have found, that they think there is actually an intrapulmonary shunting, whereby the infection leads to a local interstitial edema that located in the interface between the lung structure with the different elastic properties. So the stress and the strain are concentrated. Number 2 is the loss of lung perfusion regulation. The ACE2 actually is a principal receptor that actually internalized by the SARS-CoV. So the low level of ACE2 will lead to a pulmonary vasoconstriction. Another hypothesis, they said that the reason why they have a hypoxia is because of the intravascular microthrombi, whereby this is due to the acute inflammation, the endothelial injury during the cytokine storm. And another cause is due to the impact diffusion capacity, because it affects the type 1 and type 2 cells alveolar, whereby you have the alveolar collapse. So basically, it will impact the gas exchange. And other causes that would actually being hypothesized due to the hemoglobinopathy and also carotid bodies being affected, and therefore there are no regulation in terms of the respiratory rate. So the COVID-19 and the lung. So basically, what could happen? So you've been listening about the organizing pneumonia ever since I think about a year ago. So you are familiar to the OP. But what is OP all about? So there's one study, I think, in looking at an autopsy specimen in 21 patients. So what they found is primarily show an exudative phase of diffuse alveolar damage, with the minority displaying the organizing or proliferative phase. And what does this mean? So clinically, this patient has a ARDS or acute lung injury, and in your imaging, what you could see is a diffuse pulmonary infiltration. So you see a diffuse ground glass bilateral lung, and histologically, this could represent the DAD, and also some of it as a organizing pneumonia. So in our context, when we talk about from respiratory point of view, when we talk about OP, so OP is not technically, it is not clinical diagnosis, but it can be described in your imaging, it can be described in your histology as a pattern, and organizing pneumonia also can be adapted into a clinical diagnosis depending on the cause of it. So when we talk about interstitial lung disease, we have organizing pneumonia listed under idiopathic interstitial pneumonia, which we call as a cryptogenic organizing pneumonia. Why I want to highlight this, because some of us may actually confuse with COP and OP. You know, so the OP is just an entity that just telling us about it is a response to a lung injury and a process of pulmonary tissue repair that could be either due to idiopathic or unknown cause or secondary to a lung injury. And it could also histologically described as an OP, which associated with pulmonary lesion of another nature. Means that if you have a patient with, for instance, hematological malignancy with a lung manifestation, if you biopsy the lung, you could actually find an OP over there. But the OP does not mean it's the same context. And in your cryptogenic organizing pneumonia, this OP is because of the underlying hematological malignancy. If you treat the hematological malignancy, the OP will resolve. So there are many causes that actually contributing to the secondary OP. So one of it is infection, drug toxicity, drug intoxication, for instance, and organ transplant, and many more. So in our context, it's a virus, which what we want to talk about is the COVID-19. So from previous histories of SARS, because it's from the same variant family, so it shows some similarity of what have they gone through. So from once the SARS actually infected to the host, and there will be acute stage that lasted for 7 to 10 days, and followed by a medium phase whereby the lung is started to organize following an acute viremic phase. So this whereby the medium phase will show fibrous organization, some fibrosis, and then this fibrosis may become more extensive with time. And at later stage, where they call it as at a fibrotic stage, the lung will exhibit a dense septal and alveolar fibrosis, and the time duration that counted from this symptom and the pathological does not always evolve through all the stages. So may be cease or recover at any phase. So not all our hosts that being infected by the virus will go through all the stages. Some may actually go to acute stage and step to late stage right away, and some may actually follow the sequence of the phases. And this all depends on the host response. So there is like the entity they call a term of immunosenescent or inflamed aging. Whenever the host actually being infected by a virulent virus, and they try to actually respond accordingly. But as I said, it depends on the host. The host actually have a very good binding capacity between the virus and also the host, and perhaps the response will be overzealous. And if there is also an individual that actually will respond just nice and appropriate, they will recover even faster following the hyperinflammation phase. So what have they described? So they try to actually adapt in the COVID-19. So the phases of the diffuse alveolar damage before after the exudative phase, followed by an organizing phase, and then lastly will be the fibrotic phase. And bear in mind, after the hyperinflammation phase, what happened? This will actually lead to what they call an organization. This is where they call the phase of the organization of the lung. So some sort of a repairing of the lung. So the repair of the lung, it will decide whether the extracellular matrix stay or the extracellular matrix will go away. So in some hosts, they able to actually resolve or remove of extracellular matrix even without any intervention. Means that after dexamethasone up to 10 days, when the patient recovered and under room air and discharged, there will be a residual lung infiltration, but the patient is well. If you follow up the chest X-ray, you could observe there is a resolution of it. So basically, there are hosts that able to actually resolve or remove of the extracellular matrix, and they will resolve without any fibroproliferation sequelae. However, in a patient that unable to take out the extracellular matrix, there will be a residual fibrosis with pulmonary dysfunction. And this pathological fibroproliferation, the pathway is the similar what we see in a patient with idiopathic pulmonary fibrosis. So those with old age and usually male as compared to female, smoker or former smoker, and those with the comorbidities like hypertension and diabetes. Either they recovered with a permanent fibrosis or they recovered without fibroproliferation sequelae, but in a longer time as compared to one host that able to remove all these extracellular matrix. So there will be two outcomes of our patient after COVID-19 hyperinflammation phase. So in the lung, the normal wound healing response to injury, not just in lung, in other things as well. So you have a secretion of growth factor and all the extracellular matrix migration, and there will be a tissue repair. However, in a pathological, that the one that have a pathological fibroproliferation pathway, so they try to repair, but they will end up with fibrosis. Okay. So we move on to the imaging of a COVID-19, and I think this is not something really I think this is something that really you are familiar with by now. So when you do a high resolution CT or be it CTPA, what you could actually found on the parenchyma will be the ground glass opacity. So there will be a pure ground glass or mixed ground glass with consolidation. So these are the most typical pattern in COVID-19. And you could observe this during the hyperinflammation phase. And these are the frequency of the chest finding in the COVID-19 that has been illustrated in this study. So again, they emphasize the ground glass is the most commonly found on this CT scan in a patient with COVID-19. And you could actually found as well, besides that, they could actually have a bilateral distribution or peripheral distribution. And they could also have some sort of a stick-like opacity. So all these are patterns just telling you that there is a injury to the lung. So these are another picture that perhaps just telling you of one pattern. So basically, you could see a ground glass opacity, but with what they call is a perilobular pattern. What you could see here like an arcade-like pattern. So this is what they call a perilobular density. Some of it look like a band consolidation or a consolidation. This is what consolidation what we see in described in organizing pneumonia. It is pretty much different from your consolidation in bacterial pneumonia, because that one you could see an airborne program, and the volume of the lung perhaps is a little bit increased as compared to the organizing pneumonia in this context. And this is what they call as an reverse halo sign or atoll sign. So basically, another pattern of what is described in organizing pneumonia. And this is also, they call it a fibrosis band of organizing pneumonia. So I put it in a description here. So just now, just a random picture. So the classic form for OP pattern of radiology would be the multifocal parenchymal consolidation, like what has been illustrated here. It could also presented like a nodular form, be it a solitary or multiple nodules or masses. Reverse sign, reverse halo sign or atoll sign, and there's also band of consolidation. Perilobular abnormality. If you read the CT report given by the radiologist, you would appreciate the report saying that the perilobular density, and this is what they meant by the perilobular density. This is the secondary lobules of the lung. So it is actually lining up the perilobules. And there are also a pattern that they call it a progressive fibrotic pattern. This is also what we call as an OP pattern on radiology. So OP in this manner is a pattern on a radiology. So this kind of pattern also you could observe in the cryptogenic cause. You could observe also in the drug toxicity as well. And you could observe also in a patient that come with the other manifestation, other disease like hematological malignancy with the lung manifestation. The OP also can be appear or like one of these patterns. So this paper actually looking at what happened if they do a CT scan at any point of stage during the course of disease. So what they have found, even at the very early age, there will be a CT changes. So very minimal, scattered, ground glass opacity. But again, we would expect this patient perhaps even at category 1 and 2. So basically, with or without CT, you still be able to diagnose a COVID-19 based on your PCR or RTK, and also based on the symptom as well. So you do not have to have a CT scan to diagnose these minimal ground glass changes. However, sometimes a patient with an early stage, perhaps moving towards in the middle of your viral phase, going towards to your pulmonary phase. So maybe they will actually have this multiple ground glass opacity, which also been described as an organizing pneumonia. So if you remember, OP is a response to a lung injury. So in our context here, the one that injured the lung is the COVID-19. And if you look at the later stage, you could also see a perilobular pattern here at the rapid progressive stage, but this is still at an early stage, means that the host is respond very aggressively. So they try to proliferate and fibroproliferate at the same time, try to repair the lung and try to respond to the injury at the same time. And this is what happened at the centroid. Sometimes what they have, the consolidation stage, they try to organize. And later on, all these will be diminished and disappear. So again, looking at the radiological aspect of COVID-19, and we do not actually call it DAD CT scan, but I actually take it from this paper. So DAD is a histological description. We do not actually describe DAD on imaging or on a CT scan. So this is just telling us a diffuse ground glass opacity appear to be like ARDS depending on the clinical presentation of the patient. So treatment COP. Okay, I just want to highlight the COP first, and later on only we talk about the treatment for hyperinflammation in COVID-19. So people always mix these two terminologies, COP and COVID-19 OP. They thought it's the same. In COP, there will be a rapid improvement following a corticosteroid treatment, both clinical and on imaging. And COP require a very high dose steroid. So be it whether it is a parenteral, you use IV methylprednisolone up to 1 gram over 3 to 5 days, or you could actually give oral prednisolone minimum 0.75 to 1.5 milligram per kilo per day. But from my personal practice, so since my special interest is in interstitial lung disease, usually for my COP patient, I would just give them up to 1 milligram per kilo a day, because we don't want the steroid toxicity to happen quite rampant in the patient, and followed by a steroid sparing agent. And other agents that been used for treatment for COP include rituximab fosfamide. And the but it could occur over a year. So it's a high dose and prolonged treatment. Okay, so this is for COP. But for patients that actually have OP with a secondary cause, especially for infection, the gist of the treatment, the mainstay treatment, is you give a recommended dose, not a high dose. So as until today, we don't know what is the best dose, what is the best and accurate or appropriate steroid dose for our COVID-19 hyperinflammation phase. But what have they recommended based on recovery trial is the 6 milligram daily dexamethasone that could be used up to 10 days. And you could actually use an alternative with a methylprednisolone 1 to 2 milligram per kilo a day. So slightly lower, not high dose as compared to your cryptogenic organizing pneumonia. And the tapering dose will be even lower as compared to what you use in a cryptogenic organizing pneumonia. And the tapering dose also is not as what we do in a cryptogenic organizing pneumonia, whereby we go for 2 to 4 weeks weaning. But for COVID-19, following COVID-19 pneumonia, especially the one with the Cat 4 and 5 that receive methylpred and dexamethasone up to 20 milligram, we will just, it will be suffice to actually taper it with 0.25 to 0.5 every 3 to 5 days. So the reason being is, number one, we do not want a lot of steroid toxicity that occur in the patient. The complication from steroid, especially infection. You're treating an infection, inflammation that triggered by infection, but bear in mind your steroid will actually trigger another infection. So we just want to give just nice, and the rest will, the host will actually absorb all the matrix that has been produced during the hyperinflammation phase. So during the cytokine storm, so what we have learned earlier, the cytokines, which include the interleukin-6, that's where you have your targeted treatment using your tocilizumab, and also now they're using a lot of baricitinib in number of patients. So even the WHO, NIH, IDSA actually recommended 6 mg as the max dose up to 10 days. And from other studies also, I think for ICU, they use 20 mg DEXA for 5 days, followed by 10 mg for another 5 days, so 10 days in total. So there are various of doses and also a type of steroid that have been used throughout the world. So there's no standardization, but the one that we try to adapt is actually using the dexamethasone 6 mg. So this is being produced by our intensivist colleague. So they have actually come out with a recommendation. If a patient with a level of oxygen, what would be the dexamethasone dosage and the duration of treatment. And this is from Sungai Buloh. So if a patient that actually use the standard care of treatment, 6 mg, or depending on the BMI as well, if the patient persistently to become more hypoxic with the raising persistent high CRP, you could actually escalate to methylprednisolone 2 mg per kilo or Dexa 20, or even more hypoxic on top of your escalation one, you can go to the second phase, second step, which is using 2 milligram per kilo methylpred and also your targeted treatment using tocilizumab or baricitinib. And other systemic review of registered clinical trials also using a random doses of steroids ranging from 250 to 1000 milligram with a range of many days. So it could be 3 days up to 5 days. And this is what a clinical trials that they at this point of time when I put it actually still not yet recruiting, but they are recruiting the patient. So the no COVID trial actually try to standardize the oral prednisolone. So we do not have the final outcome of the study yet. So what they actually use is actually a higher dose. If you notice, the dose is similarly what they use in a cryptogenic organizing pneumonia. Even at the tapering dose also as similar as what we practice in a cryptogenic organizing pneumonia. And this is followed by after an acute hyperinflammation, the patient receive courses of steroids, and this will be the tapering dose of the steroid that the patient will be discharged with. And you saw some fibrosis component. So during the pathogenesis, even the imaging can actually show a fibrosis. So whether any potential role for antifibrotic, so far they have not described, but the antifibrotic that available in our country are the first two, which is nintedanib and pirfenidone. They could actually see a signal, and means that they could actually these two antifibrotic could act on both interleukin 6 and also interleukin 1. But of course, again, there are trials looking at all this. So whether the nintedanib and pirfenidone have a benefit in our SARS-CoV-2 induced pulmonary fibrosis or COVID-19 pneumonia is we're still waiting for the end result. We're still recruiting the patients. So because of this virus infected so much on the alveolus, so it caused interstitial abnormality with a persistent inflammation, and this will derive that maybe, or there are also several reports that suggested development of pulmonary fibrosis in a subset of patients. And this is not something a surprise, because if you look at the pathway just now, there are hosts that are able to resolve and there are hosts that will not able to resolve the extracellular matrix. But however, we do not have this long-term study. Perhaps in 5 to 10 years' time will tell whether we have a COVID-19 induced pulmonary fibrosis in future. So following which, this is an observational study of corticosteroid treatment. So after discharge from hospital, so there are 7% of patients that has a persistent interstitial change on CT scan. So this is after 6 weeks, and how they intervene this, they offered treatment with corticosteroid 0.5 and taper over 3 weeks on average. So all these patients who received reported subjective improvement in breathlessness and physical functioning, and has objective improvement in lung function and chest imaging. So in such a manner, we would like to actually, this study just to like to reiterate that the steroid also has role even after post-COVID-19 acute phase. So this is an classification of interstitial lung disease, which comprises of your connective tissue related, idiopathic cause, granulomatous, and other forms. So what I've mentioned earlier, maybe in future we're looking at this, we are still not sure. So looking at how IPF occur, so this is one of the subset of your interstitial lung disease that occur in men, elderly, former smoker or smoker with unknown cause of pulmonary fibrosis. So one of it, they said that chronic viral infections such as Epstein-Barr and hepatitis C has been described that could be one of the cause to cause IPF. But this is a statement that has been presented in 2018. Maybe in 10 years' time, COVID-19 will be one of the viral infection that may actually trigger the IPF. So after the intervention of with medication or pharmacological, so not to forget, one of the recovery of our COVID-19 is the pulmonary rehab. So pulmonary rehab is something feasible, is safe, and it is an effective therapeutic option in COVID-19 independent of disease severity. So be it in even in Cat 1 also, you could actually propose a pulmonary rehab for your patient. So this is an incentive spirometry that actually help in terms of because the muscle that help you breathe need to be strengthened after recover from the lung infection, and not just the chest wall muscle but also the diaphragm muscle. So the incentive spirometry really helps in terms of to strengthen the muscle and also to address the weakness and the muscle loss, especially for patients that stay in a longer in a hospital. So what we do in IPR, we prescribe this to all our patients. So we ask them to sit upright on a chair or at the edge of bed, hold the incentive spirometry on an upright position, and breathe out normally, and place the mouthpiece in their mouth and seal it properly. And they will actually breathe out to make the ball go up, and breathe in to make the ball go out. So this we advise to do about 15 minutes a day. You could break up to about 3 sessions, 5 minutes. So this is what have been practiced, and this also have an impact in terms of your breathing pattern, and also the exercise capacity, and a better quality of life later on if it's done consistently. And besides breathing exercise, we also encourage walking, proper positioning, and of course monitor the pulse oximeter, because not this patient, when they recovered, they will not go back to their normal saturation, which we will expect 95% and above. So then we should encourage them to do all these exercises so that they will have a target when they monitor the pulse oximeter. So do we have any post COVID recovery program that being offered? So IPR do not advertise as what the private hospital advertise. So so we do have a pulmonary rehab program that tailored to our COVID-19 patient, but we choose our patient. So the one that will benefited most will those with a category 5 and I think 4B. So basically, they will want, if let's say we transfer them from HKL to our hospital, so our physio will start the pulmonary rehab session. And if let's say the patient able to be independent, means that one of out from oxygen therapy, number 2, they able to walk with assistance, and then they have a good family support at home, and we will actually do it the subsequent session as an outpatient. So it can be in and outpatient at the same time. So besides that, you can actually Google up physio post COVID-19 physiotherapy advice. This is from NHS, from the UK, and also a patient guide. So this is something like a booklet that the patient can read. It is a very easy to understand because it's in layman term description. So basically, what exercises they will expect to do, and how frequent they should do, and what would be the expectation would be. And how do you intervene? So basically following a discharge. So patient after discharge, they will go for a follow-up. So in IPR, we offer to actually follow up category 4 and 5. So after a period of time, so basically what we give now, ideally up 6 weeks after discharge, 4 to 6 weeks. So from this algorithm, they say at least 2 to 4 weeks, but it is not something really possible and realistic to do at this moment. So from our point of view, from our practice, we see them after 6 weeks. So basically, they are patients who recovered, then we managed to actually discharge at first visit. The only thing that, let's say the patient has been followed up elsewhere and they have a persistent X-ray abnormality, that's where will be the referral to us comes in. So then we will do the appropriate investigation following that. Even in the BTS also proposed actually even longer than 6 weeks. So they have a facility to do a teleconsultation 4 to 6 weeks after discharge, which we could not actually do this so. So after 3 months, they will assess the patient with chest radiograph and some clinical assessments, some pulmonary function tests. This is from respiratory interest point of view. So for any other clinic that would like to actually open up a post-COVID clinic, chest X-ray and clocking the patient would be sufficient. So for the other respiratory component, that is just mainly for respiratory interest only. So if there is a persistent abnormality, they will go for a high resolution, repeat high resolution CT. If let's say they're normal, they will discharge the patient. It's similar what we do now. So this is where the IPR comes in, and this is patient who actually with a mild to moderate. Earlier is the algorithm for those with the ICU admission. So IPR comes in after the respiratory comes in only after there is a persistent abnormality on chest radiograph and there is a persistent symptoms of respiratory. So this is a post-COVID-19 management protocol. So they put it as organizing pneumonia diagnosed. I think this term is perhaps a little bit confused. So maybe a patient with a category 4 and 5 discharged with a tapering dose methylprednisolone or require a methylprednisolone during the acute phase. So they will be followed up 4 to 6 weeks, similarly what we're doing now. So what we look at actually looking at the side effects of the steroid and also the glucose control, especially for diabetic and also newly diagnosed diabetic during the admission, and the chest radiograph. And following that, we could actually follow up about 12 weeks, consider lung function if only persistent chest X-ray abnormality. We could discharge if the patient has improved, and if not improving, then we could actually proceed with the high resolution CT or CTPA, depending on what will be the abnormality that you're dealing with. So I'll be ending out with a few case sharing. So this is a case with a persistent fibrosis post-COVID-19. So we have out of from close to 400 patients that we have followed up since last year. So I think only about 3 patients that have a persistent fibrosis. 3 of them are actually male, and one of it is my patient that under follow-up interstitial lung disease. Unfortunately, he got a category 5 COVID, and the ILD actually the fibrosis has been accelerated by the COVID-19. And this is a case that a man undiagnosed with any form of interstitial lung disease presented with the COVID-19, ARDS, intubated. This one sometime in the middle of last year, extubated and went home and revisited the emergency department because of breathlessness on exertion, and admitted in Sungai Buloh and referred to respiratory for consultation, and we took over the patient for further management. So clinically, there's no finger club, gastro hurt by basally. So when we do when we perform the lung function test, this one is at close to 3 months after discharge. So the forced vital capacity read at 51%, which is low. So this read as a restrictive pattern. So the normal is anything above 80%. So he could only walk 120 meters in 6 minutes. So we would expect 6 minutes, the patient could pass more than 350 meters. So the desaturation you can't see marked because there is the distance somehow rather shorter. So you not actually induce some stress on the patient to see the significant desaturation. So when we look at the ABG, the PaO2 under room air is 76 for someone who so far breathlessness. So we perform some connective tissue screening just to make sure that there's nothing to cause the lung fibrosis. So what have we found on the X-ray? Sorry. So if you look at the X-ray when he first came in before intubation, so just some very non-specific pulmonary infiltrates, but you can diagnose as COVID-19 because his PCR is positive. This is after intubation. What happened to the lung? So you see more lines at the bases, and you see the diaphragm is actually elevated higher. The left hemidiaphragm is higher than the right. So when there is so you think you must think of whether it's collapsed, but the diaphragm looks the contour is normal, or there is a volume loss because of a scarring or fibrosis. So the subsequent chest radiograph even showed even more prominent reticular nodular shadows that represent of your fibrosis here. So when we look at the CT scan, this is something like fibrosis, so traction bronchiolectasis, asymmetrical, so more on the left hemithorax. On the basis part, you could actually observe bilaterally. So this is 4th week of illness, and this is after 2 months. So this is more towards like a ground glass, and this is more causal in terms of the fibrosis. So technically, this pattern does not represent as a organizing pneumonia. This is more towards a pattern what we call a usual interstitial pneumonia or pattern. So this is more consistent with the idiopathic pulmonary fibrosis pattern rather than post-COVID-19 pneumonia. So hypothesis for this patient is that he has a undiagnosed pulmonary fibrosis, had a COVID-19, and the virus actually triggered this IPF to be more pronounced following the post-COVID-19 infection. We go to the case 2. Okay, 62-year-old female, non-smoker, diabetic hypertension, Cat5. So she received quite a high dose of steroid with the prednisolone tapering dose. So a lot of complication ongoing during the hospitalization. And she has a vocal cord injury during the intubation. And I think she visited ED once, the complaint of wheezing. During sleeping, wheezing even worse. So no past history of asthma. So whether she developed asthma or something else. So she was referred to us for further evaluation. So I performed a spirometry, and what could we see? Although the FVC is normal, if you remember, I told you FVC anything above 80% is normal, but the graph is not normal. This graph shows a flattened expiratory limb. This is indicating of upper airway obstruction. So what we do in the you can see a granuloma that obstructing the just below the vocal cord, right? So basically, this is a granuloma tissue following a vocal cord injury after following intubation. That could represent like a wheezing. Actually, could be it is a stridor. So referred to our ENT colleague, and they excise the granuloma, and the patient get better following that, and there's no so-called asthma after that. So case 3, a 58-year-old female, non-smoker, no medical illness, category 5, intubated, received a very high dose of methylprednisolone, 3,500, and with the oral prednisolone 60 mg daily tapering dose. This case, I just want to illustrate that our cases does not require a high dose tapering dose of steroid. I think they give cap of 60 max, and they tapered every 5 days. What happened after discharge? She can't sleep at night. All these are telling you the steroid toxicity, unsteady, especially climbing stairs. This is because of the steroid myopathy, increased appetite, weight gain, and all these are steroid side effects. And we tapered down the prednisolone quickly, and her FVC 60% is still restrictive. But if you look at the chest radiograph, this is her chest radiograph when she presented in hospital. So this is a CT scan. This is the chest radiograph when she saw us, I think roughly about 6 weeks, when she's still on a prednisolone. So 16 milligram every 5 days, so roughly about 30. So at 30 mg, you could see a lot of improvement in terms of the chest radiograph as compared to before. So her CT scan, of course, you could observe, oh, sorry. I'm not sure, maybe the video is not working, but never mind. So just want to show you that the chest radiograph definitely improved during the tapering dose of steroids. So it means that you do not have to give so much high dose steroid. Patient has a lot of complication following the high dose steroid. So this is a gentleman that referred to us for follow-up. So in November 2020, when he came with the FVC of 59%, and this CT is during the illness. So this is about in October, so a month ago. So when we follow up with the CT scan, after about 3 months or so, this is what happened. The same cut, so the resolution of the organizing pneumonia. So this is the band of organizing pneumonia. Some sort of like just a thin fibrosis, and some of it will not go away. So this is the best CT resolution after 3 months. Maybe if we prolong it 6 months, you can even see even better improvement in terms of the radiologically. So FVC is better, 59 going to 105%. It's a lot better. MMRC 0. I could actually sign off for him to go back to work after 3 months of illness. Case 5 is a case with comorbid bronchial asthma, 49, Malay, non-smoker, COVID-19, initially intubated for asthma for a day, and third week of illness, developed tachycardia and desaturated, thinking of acute exacerbation of bronchial asthma. This is what happened after third week of illness. Of course, you could observe the organizing pneumonia. This organizing pneumonia just settled with the IV hydrocortisone. You don't have to actually give metipred or even Dexa. So she was discharged with the prednisolone about 20 milligram taper every 3 days. And this is what she reported after 6 weeks of discharge. No more cough, no breathless. She still used a Symbicort, good control. Of course, the FVC, we do not actually observe going to be normalized even 6 weeks. Even from the previous SARS study, they observed only after 6 months, the lung function test will be normalized or close to normal. So this is a chest X-ray on our follow-up. So it's much better. So last would be another case that complicated from the steroids, 28, female, obese, admitted in mind with category 4, highest oxygen is only nasopron 3 liters, but she receives up to dexamethasone 20 milligram daily. And admitted after 1 week discharge with TKA and septic shock. So this is one of the readmission to emergency department. So this is her chest X-ray on the 17th July when she was readmitted back to the emergency, intubated, mainly for DKA, but being diagnosed so-called as a category 5, which we revised the diagnosis following that. This is her chest X-ray where I did when she was transferred to IPR after the 17th of 7. And what could you observe? Here, there is a very huge cavity with a minimal air fluid level. She has a lung abscess. That could actually maybe one of the cause of the DKA, and her poorly controlled sugar during the ward stay. And this is the recent one. What she developed is actually also parapneumonic effusion, and I think becoming an empyema as well. And she grew MRSA, and we giving her IV Vanco for a total of 6 weeks plan. So just to show what our services here, so what we do during our follow-up, patient will perform a lung function test, spirometry will do, only Cat 5, I would just order for a diffusion capacity to look at the gas transfer. And this is our physio that doing the 6-minute walk test and some rehabilitation for our outpatient patient. And these are the patients, both are category, so COVID-19 requiring high flow nasal cannula. This is last year still categorized as a 4. So these two patients are still working, and they complain of breathlessness with oxygen saturation of 96%, more fatigue. So it's more towards the deconditioning. And she actually practiced how to climb the stairs because she has this very bad myopathy following a high dose steroid. So all this rehab really helpful to them, and they went for an 8-session rehab, and the outcome was good, and we able to discharge them about early this year. And this one of my ILD patient who has a persistent lung fibrosis following a COVID-19, 99 days hospitalization, discharged with oxygen, 3 liters, and now after 6 months, which he is able to off oxygen. I just signed him in to actually he is fit to work soon. He's able to walk without walking aid now. And this is our discussion on patient that has a persistent fibrosis. So we do discuss our cases in overseas experts, and also our local thorax radiologists. And this is our team that when we have a cases that we are not sure if it's a persistent fibrosis, then we will discuss in the meeting. So always the frequent asked question, what do you do if they come with cough and breathlessness after discharge of home quarantine? And do chest x-ray, always do chest x-ray. And if it's clear and hypoxic, rule out pulmonary embolism. They could get a pulmonary embolism at any point of time. It could be due to the immobilization. If clear and normal saturation, whether the patient is anxious or the patient has hyperactive airway or deconditioning. For hyperactive airway, usually I would propose to just give MVI budesonide for a shorter period use. For deconditioning, usually we will just enhance the pulmonary rehab. If abnormal but improving, either due to deconditioning, that may need a pulmonary rehab. If the X-ray is still abnormal, think of infection, complication from the steroid in diabetic or newly diagnosed diabetic. If wheezing or stridor, rule out complication from intubation such as tracheostomy. So in summary, understanding the cause of disease is crucial. Corticosteroids seem to be a double-edged sword in the fight against COVID-19, but need to be used judiciously considering the risk-benefits ratio. There's no evidence supporting long-term use of steroids with patients with COVID-19 to prevent potential adverse sequelae such as pulmonary fibrosis. Follow-up is ideal to be done to require to know the outcome of the following treatment. Pulmonary rehab is helpful to ameliorate dyspnea, alleviate anxiety and depression, reduce complication, prevent and improve dysfunction, reduce mobility, preserve function, and improve quality of life. I love pulmonary rehab a lot. I am more maybe so-called a multidisciplinary discussion is required to establish a diagnosis of specific lung fibrosis, especially in the case of a persistent fibrosis following a COVID-19 infection. Thank you so much.
Thank
Sorry,
you.
take your time.
Okay, thank you, Dr. Syazatul Syakirin.
Syakirin,
Sorry, yeah.
Syakirin, just the second name.
Okay, thank you, Dr. Syakirin. So I think our participant have some question. I will allow them to ask you some question. Okay.
Okay, sure.
Thank you, Dr. Syakirin. A very good morning to you. Thank you for your superb presentation at macrocellular level.
Oh,
I have a few questions.
Yes, sure. Who am I
And
speaking
it
to?
may be
Sorry,
up to 3.
Okay, all right.
I have a few questions and it might be silly. Just please bear with me. My first question is, you showed a slide that says the acute stage, medium phase, late stage. Does that apply to post 14 days of recovery, or it can also apply during the initial insult?
Initial insult. So It is something like a continuum, so initial insult until the recovery.
Thank you. My second question is regarding the radiological description of ground glass opacity. Is
Yes.
that a term that is used in Hrct only, or can it also be used on X-ray?
Okay. From what I learned from radiologists, they rarely use a GGO description on a chest radiograph. But I know somehow we do not have some words to describe. We tend to actually use GGO, but the GGO term is actually being used for a CT scan, a CT thorax mainly, rather than a chest radiograph. So chest radiograph, you would just say opacity.
Okay, thank you very much. My next question is regarding the Velcro sound on lungs.
Okay.
I've never heard of that. Can you please just...
Background sound of the lung is just telling you that there is a fine inspiratory crackles. So during the inspiratory phase, to tell you that, oh, this is consistent with pulmonary fibrosis, because you have a lot of fine crepitation on auscultation. But which fine crepitation that actually this is due to fluids, and which one is actually due to bronchiectasis is cause crepitation rather than fine. So which one is actually belongs to the lung fibrosis? So the one that during inspiratory phase and fine inspiration that is more towards your lung fibrosis rather than your heart failure. So it's just the terminology that we use for prescription for the fine inspiratory crepitation in a patient with the lung fibrosis.
Okay, thank you, doctor. My last question is, if a patient had been infected with COVID-19 and let's say they were infected with the Delta variant, can he or she be reinfected again with another COVID-19 variant? And can this cause double-edged sword injury?
That one good question. I suppose yes, but I think the best person to answer that will be infectious disease. But from my best knowledge, which perhaps is a limited knowledge, yes, they can actually be infected after with another variant.
Okay, thank you, Dr. Sri Rao. Actually, there is one question from the chat box from Dr. Omul, emergency physician. How to differentiate between OP or superimposed bacterial infection or COVID-19 pneumonia, especially when patient come at a very slightly late stage, day 14, like that.
Right. So good question. So you just take it the organizing pneumonia as just the pattern of response of whatever that inject the lung, and also as a response towards as a process of repairing mechanism of the lung. So be it whether the cause of whether is it COVID-19 or whether it's a superimposed bacterial infection, this one you need some additional information. Means that you still have to go by your total white count, your CRP, and then your cultures. That will tell us what sort of cause that you're dealing with. Is it still due to the COVID-19 or now it's a superimposed bacterial infection? And it is not wrong to stop the steroid. If you have a bacterial infection and patient is in sepsis, and you have a CT scan that read as an OP, and I understand there are people that really already have a fixed tune that you need to treat the OP with a steroid. But bear in mind, the OP can actually subside eventually, even without intervention. So don't worry about that. You treat the acute presentation, means that the infection first. So you could stop the steroid. If let's say the patient has septic shock, maybe you would start the steroid as per septic shock protocol. But the antibiotic comes in, and we do see few cases that we did just stop the steroid and treat the infection, and the patient recovered quite well, similarly as the patient with the so-called OP with steroid without infection. So technically, that's why I'm emphasizing. We do not have to actually taper with the high dose steroid upon recovery. So just a tapering dose of the low dose steroid is just to mainly to following after a high dose steroid that the patient receives, especially those who receive metylprednisolone or Dexa 20 mg and above. So this is to actually to tackle the HPA axis that has been disturbed. So basically, you just want to tail down properly so that everything won't crash, So you don't have the hypoadrenalism manifestation following or stopping suddenly the high dose steroids. That's another intention why we give the tapering dose of steroid. Any role of inhaled steroids? I think there's one paper actually come out with the inhaled steroids, but we are not actually practicing yet. But I give inhaled steroids for patients with the hyperactive airway following post-COVID. Means that they come after 6 to 8 weeks in our clinic. They have persistent cough, and there's no. Basically they are not asthmatic. It's just something like what you deal with the hyperactive airway following a virus infection. So we give a temporary short-term budesonide or even Taxotype also will do. So 2 to 4 weeks, and some of them recover quite well following that and able to stop the inhaled steroids.
Okay, thank you, Dr. Syakirin. Any question from the online participant? If no, I think that's all for today. Okay, so thanks to Dr. Syakirin again about regarding the very informative and interesting presentation. Is there any last take-home message from Dr. Syakirin for us?
Oh, the last take-home message, I think the FAQ, if the patient revisited after the COVID-19, but you're not just seeing those who are actually discharged from the hospital, but also the one with the home quarantine. Because I think the cough and the breathlessness, they will experience it, even with whatever category. So even Cat 1 also patients do experience the fatigue, which they thought it was a breathless. So we do the basic thing first before you embark to further imaging, the chest radiograph, and look at the oxygen. These two main things for respiratory point of view. Then you work out on whether it is normal or abnormal and see whether you are dealing with a pulmonary vascular complication or infection. And the pulmonary rehab is something that people always forgotten. But of course, we do not have a proper program for that to refer to. But of course, patients who refer to IPR, they got the opportunity to undergo the pulmonary rehab program for those who are selected one. Okay?
Okay, thank you, Dr. Syakirin. Yes, agree about the pulmonary rehab. So I think for now, we all know about it. So we'll try our best to improve the post-COVID management for our patient. So I think thanks to all. Thank you, and we close our session for today. Thank you.